I chose breast surgery because I see women in a very difficult stage of their life, and I can help them through making decisions about what kind of surgery they need to have, and then I see them in follow-up. So it's unlike any other kind of surgery where you just fix a hernia and you see the person a year later, and then basically you never see them again. So I get very involved with the patients, their families, sometimes their daughters, sometimes even their granddaughters, and it's very rewarding. Breast surgery has really changed a great amount since I started about 30 years ago. And we used to do radical mastectomies, and now we're doing lumpectomies and nipple sparing mastectomies. So women wake up looking almost the same as when they began the surgery, and I think they feel very whole. So the whole surgical aspect has changed a great deal, as well as the medical oncology aspect, which has also changed a great deal, and the survival rates are excellent. Well, I'm very honored that I was chosen to be part of the Breastlink New York team. We are the anchor on the East Coast here in New York. We went out and visited Breastlink in Orange, California, and we were very impressed by how well you can take care of patients in one center. And so we're very happy to be building a breast center here in New York and have access to all kinds of interdisciplinary disciplines, really, from genetic counseling to plastic surgery. Patients with dense breasts are complicated patients because their mammograms are difficult to read. So we always order an ultrasound with the mammogram. So we have to look at the mammogram and the ultrasound. Women with dense breasts have a higher risk of developing breast cancer. So because the mammogram isn't such a good surveillance tool by itself, we have to use ultrasound. So for those two reasons, but both the mammogram is not a great tool, and also because they have a higher risk of developing breast cancer, we see women with dense breasts more frequently. Sentinel node biopsy is a new technique that started about 15 years ago. And breast cancers can spread to lymph nodes under the arm. So in the past, to determine whether a breast cancer had spread to the armpit lymph nodes, we would take out all of those lymph nodes, and the pathologist would look at 15 or so lymph nodes to determine if there were any cancer cells in the lymph nodes. Sentinel node biopsy enables us to take out one or two sentinel nodes, and it's much more accurate. So firstly, the patient has a much smaller operation, so the downside to her arm function and to getting lymphedema is very low. And secondly, the pathologist has only a small amount of tissue to go through, so the pathology is much more accurate. So if a patient has a negative sentinel node, then it's truly negative. The pathologist has looked at this node in many sections, and it is definitely negative. So that tells us that the breast cancer is limited to the breast, and it will tailor our radiation and our hormone therapy or chemotherapy better for that patient. I speak to the patients in great depth about what are their concerns. So there are some women who would like to have a full mastectomy so they don't have to worry about getting a breast cancer in the future. And some women would rather preserve their breast. So it's just a question of how worried are they and how much do they want to have surveillance in the future. So I think tailoring breast cancer care really amounts to speaking to the patient in depth. Risk factors involve mostly family history. So we really ask the patient about her family history of breast and ovarian cancer, and we have to be very careful to ask the patient about her father's side of the family, because a lot of people forget that their father's mother, in other words, their paternal grandmother, if she had breast cancer at a young age, she could have a BRCA gene that's going through her father. So we really have to be very careful about asking a lot of details about the family history, and especially about the paternal side. Then we also ask about previous biopsies. So we ask about whether the patient had lobular carcinoma in situ or atypical lobular or ductal hyperplasia. There are also other risk factors which are less important, such as age of menarche and age at menopause. But those risk factors are nowhere near as important as family history.